they're in a bind in terms of health insurance and providing it to their employees. So we're going to talk a little bit about that. And then we're going to go on and talk more about the concept of the single payer, which is being developed in New York, in the state of New York, and it's been in a process for several years. We want to talk about that, what it is and what it isn't. You'll hear a lot of things nationally. We go single payer, we go Medicare, etc. We're going to sort that out, and we have an expert here to help us understand that. Once we're done with that, we have two additional physicians who have volunteered to come and talk with us. We have a little panel here in terms of any questions you may have, issues you may have, because I think it's important to understand if you do single payer, you've got to consider the physicians, you've got to consider the hospitals, you've got to consider the employers, so it's a very complex kind of picture. Okay, that's what we're going to accomplish tonight. I want you to leave tonight knowing more about this, perhaps more than you thought you would know, but also probably with some questions and see what may fit in your personal situation, or if you represent an employer with your employees, what that may look like too. Okay, let's look at Dutchess County. Dutchess County is 17th in its health status among all the counties in New York. Last year it was 10th. So it has fallen back in terms of a lot of indicators. And
how many counties are there in New York?
I think there are 67. 62. 62. So we're 17th out of 62. Last year we were 10th. The county is 20th in the length of life, how long you live. How many, and they measure that in different ways, but typically they say how many people reach the average age of 75, and those that don't reach 75, they calculate that. And they rank us 20th in length of stay, in length of life, and 19th in quality of life. Now here's an interesting thing. Every year in this county we spend $3.5 billion to provide health care. Now that's not just insurance, it's money out of our pockets, it's money out of employers, but $3.5 billion. So you're starting to talk about money here. Chronic disease, diabetes, arthritis, COPD, accounts for 40% of those costs. Now, there are probably 10 primary chronic diseases that we know of. There are a lot of others in terms of classification, but those eat up a lot of this money, and there are a lot of opportunities with chronic disease to get to it early, to manage it, etc., to save a lot of dollars. And as we get through this, single payer has a lot of ideas in terms of how to integrate that. $120 million a year in this county is spent for diabetes. It's an expensive chronic disease. It is and we are able to identify it, we're able to manage it, but we still don't do that effectively. Now, Medicare is coming out next year, 2018, with a program that will bring a very rigorous program for diabetes to the Medicare population. We're anxious to see that model and see if that can be applied to the rest of the population. I'm sure it can. 26% of the adults, me included, in this county are obese. More than 26% of the students in our high schools are obese. And obesity now is starting to be considered a chronic disease because of the impact it has in all of the diseases. It contributes to a lot of the chronic diseases we see. And so we're starting to recognize that as a chronic disease, something that you can do something early about, something you can manage, etc. And I say that right after Halloween. Okay? 15% of the high school students in this county don't graduate. Now you say, well, why is that important? If they leave high school with no degree, what are they going to do? What's their education? How can they integrate a lot of health information? How can they maintain their health? What are the odds of them being successful? And health is a big deal there. They can't afford it. Can they keep themselves healthy? and it will be an additional social cost on the county. So it's an important indicator, and it's an indicator that we look at when we talk about the health status of the county. It's one of the factors there. %, 25,000 people in this county are uninsured. Now that sounds like a lot. It was double that before the Affordable Care Act came. So Affordable Care, Obamacare, the same, have really dropped the uninsured by 50%. It's a remarkable accomplishment. But we still have 25,000 people that are uninsured in this county. So where do they end up? They end up in an emergency room, or they don't go for care, or they wait, etc. Now, Dutchess County property taxes include $41 million for Medicaid. You may have heard this was an issue in, I think it was the repeal of Obamacare #2, where our New York Republicans asked that a special thing be put into the bill that would eliminate the necessity of the counties funding Medicaid to the state. Now, New York is unusual in that, but if you were to change that and the state was to have to fund that and the counties don't, where are you going to get the money? You're going to come back in another way. So the money, the requirement for that's not going to go away. So it's sort of a shell game. But if you look, $40 million, that's 38% of your property taxes. Now, Medicaid, as you may recall, has been significantly expanded to cover a lot of additional a lot of additional individuals who are sort of in between poverty and being able to handle a lot of the medical care costs. So it impacts 31,000 people in this county, and that's significant. That's 10% of the population. Take some advantage of Medicaid. Now, we think that there are significant opportunities to reduce health care and improve the health status of the community, but it means that we have to understand where the costs are, what are we doing to raise those costs, and how are we looking at how we're approaching this. Now, I'd like to move a little bit to, this is for employers, and we give you some idea of the dilemma that we have with employers. About 90% of the businesses in the county are small businesses. There are about 7,500 of them throughout the county. What they are facing in terms of cost, and you can see, in 2013, the single payer, they had to pay for a single person for insurance, it was about $5,200. In 2025, it's going to go up probably to about, I think it's about $7,000, very close to that. For the families, right now, it's running a little over $15,000 in 2013. They're projecting in 2025, it'll go up over $20,000, probably $22,000. But you can start to see, if you're a small business man or woman running a business, and I think the good news is more women are running small businesses than men, you will face this. You will face the dilemma that can you afford to pay insurance for your employees? And if you can, what can you afford? And where does that put you then with your employees in terms of care? I think I shook it the wrong ways, probably. Yes?
Does that figure you gave the number of businesses in small businesses in Dutchess County, does that include internet businesses? Businesses that are rolling out?
If it's an internet business with one individual, no. But if it has more than one employee, then it would.
Are those costs employer costs or the total cost?
These are insurance costs that the employer would have to pay to provide some type of insurance. Now, along with that, you still have co-pays and deductibles, and you know what's happening to those. They're getting larger. So we're having to make decisions not for, can I get, I think it's Oh, here we go. That's it. We have to make decisions in terms of what kind of insurance are we going to buy for our employees, or are we even going to buy health insurance for our employees? Now, let's talk about that. This is a trend that's very disturbing as I looked at it. And it says that this takes from 1999 to 2016, what are small businesses doing in terms of insurance. And you can see that they're dropping insurance rather at a pretty good clip. If you look at the top there, business 3 to 9 employees. I'm going now. He doesn't trust me. Yeah, I know. Thank you. There's a 16% drop from 1999 to 2016 in terms of the number of people, of the number of employers that will offer insurance to their employees. Then you go 10 to 24 employees, it's an 18% drop from 99 to 216. And as your employer size gets larger, they will cover more, a higher percentage will cover that. But if you put all the businesses in the county together, we still have a 15% drop in the number of employers who have stopped insuring or providing insurance as a benefit. Which is scary. And most of the new business is in small businesses. That's where you get the growth. That's where you hire more people. And so that's a big concern of ours. As we looked at about 20, we have surveyed a number of small businesses in the county, and we have also looked at a national study of about 20,000 small businesses. The number one problem that they identify out of 74 problems that they were asked to address is the cost of health care. Healthcare insurance is their biggest problem. One of the hidden costs, too, for the small employer is, if I'm going to offer insurance, every year I have to negotiate an insurance package, and I have to go out and basically I'm buying a new policy. And what's it based on? It's based on cost, it's based on benefits, etc. And so I have to go through that. Then I have to explain it to my employees. And oftentimes we give them, the small employer will give them an option in terms of that. But it's time consuming, it's resource consuming, and you're putting a small employer who this is not their specialty into a bind to make that decision. I think that's we may talk about that later, but that's a big issue in terms of employers. Not only small ones, but also large ones. Okay. The employee, we talked a little bit about this, but we have the employee problem. Okay, I'm working for a small employer, I love the job, and they can't offer me health insurance. Or they offer me a policy that has a $5,000 or $10,000 deductible. So what do I have? I have a major medical policy is basically what I have, and I have to pay the rest. And if the average salary is in the neighborhood of $14 to $20 an hour, you're looking at $28,000 to $40,000. You can't afford that. So you're going to make other decisions that are going to affect your health because you cannot afford it. And this is a big deal for the employees and for the employers. It used to be that the health benefit was a great benefit that you sold as a part of your business, and people were attracted to you because you had that benefit. Or this is changing dramatically. And we have an anomaly in the United States in terms of employers providing insurance. About 1942, a citizen of this county started an awful thing. Not awful, but he started a thing. Roosevelt. Roosevelt was in the middle. Let's offer health insurance. And that's where it started, where the employer was expected to provide health insurance. Now, those first policies cost about $50, and they gave you about 7 days in the hospital. Not today. So if you take that simplicity thing and go from it, you'll see, okay, I'm getting the evil eye. One last slide. I think that we need to think of a different paradigm as we approach healthcare. The paradigm we're under now is we have, I call, it's my words, a sick system. We go to it if we're sick. We go to see the doctor if we're sick. We go to the hospital if we're sick. And if we're not, we don't enter that system. But there's not a system, we're not a part of the system that really emphasizes keeping us healthy. So I think we need to change that paradigm and think, how could we stay healthy? Can we get into a lot of the chronic disease? Can we get into those things that will bring the cost down and make it a little more rational? So with that, let me stop, and I want to introduce our main speaker, Dr. Leonard Rodberg, who when I talked to Len the other day on the phone, I said, "You were a physicist, right? How did you ever get into this?" And let's see if I've got the story right. What he said was, well, I was looking for a way to support myself, and I saw there were grants for urban renewal, urban growth, so I went for them. And he never looked back. But I rest assured that that physics background has held him in good stead as he tries to deal with all of the intricacies of healthcare. Ron has a PhD in theoretical physics. He's the founder of the Physicians for a National Health Program. He's former chairman of Urban Studies Department at Queens College. Yeah, okay, good. And he currently directs a company called InfoShare Community Data Services. It's very interesting because it will provide you with the kind of data that you need to look at a county or a city or neighborhoods, in the case of New York City, neighborhoods, to determine what's going on there in terms of health or other indicators that you can have an impact on it. So with that, Ron. You can do that. I'll turn this on. We have backup. Try it.
Red light should go on.
Red light, green light, red light. Okay. Okay, we're good to go.
Well, we'll see. Can you hear me in the back? Yeah. Okay, good. Okay, it's working. Okay, let's see if I'm here.
Going to, yeah.
There we go. Okay. All right. I'm glad to be here. My first long-distance trip on Metro North was quite comfortable. As was said, I was until 6 months ago teaching urban studies at Queens College. Urban studies is a field that's not more than 30 years old, and it's defined at each college by the college where it's taught. And at Queens College, we taught urban studies as a public policy program. And I taught health policy, and I also taught climate change policy, which is another lecture. I'll give it another time. I also, as David said, I was one of the founders of Physicians for a National Health Program. Members here, as you know, and as you members know, I think, you don't have to be a physician to be and I'm not, although I've been married to 2 physicians. But I do have to be interested in seeing if we can't accomplish a rational healthcare system in this country. I put on here, I put on here my own email address if you want to be in touch with me. And I also put on the email address of the chapter, the New York chapter of Physicians for a National Health Program, which is, I think without contradiction, say that it's the most active chapter in the country and certainly the largest. California chapter California's too big to have a chapter, but it has one, but it's very hard to organize. We have 2,000 members and are quite, have existed for 25 years. Okay, so that's who I am. What I'm going to do is I'm going to give you, I'm going to start at the beginning. I want to give you a background on the healthcare system and particularly on the finances of it, because the issue that I'm talking about and that we're here really to talk about tonight is how do we pay for healthcare? I'm not talking about medical care, I'm talking about the financing of medical care. Now, this is for New York State. This is how we get covered, insurance. Who pays for medical care in this state? In terms of the number of people, the population of New York State is approximately 20 million people. Approximately half of those get their insurance through their employers. That's the green portion of this. That's private insurance, and this individual insurance down here is private insurance. People buy it, their employer doesn't provide it, but they buy it themselves. You don't have to take a picture of this. I can send it to you if you just email me. I'll send you the slide. Or David can give it to you.
She's doing a Facebook Live event.
Okay. And this is the Obamacare marketplace. It's called New York State of Health is the name they've given to the marketplace. That's also private insurance. So if you add that up, it's about 12 million people out of the 20 in this state get their insurance through private insurance. This segment over here is public insurance, Medicare and Medicaid. Notice how large Medicaid is. 20% of the people, 1 out of every 4 people in this state is on Medicaid. Either because they're low income, well, always because they're low income, but some of them, about a quarter of those are on long-term care, because Medicaid is the major program in this country that pays for long-term care. Okay, so that's how we, in terms of population, get our healthcare paid for. This is where the dollars actually come from. And the most striking thing about this, you can look at it 2 ways. I'll talk about it in both ways. One is, remember, let me go back a minute. I would say 60% of people get insurance from private insurers. That is the employer-based and the individual purchase here. But only a third of the money comes from private insurance. Why is that? It's because private insurers cover the healthy part of the population, largely the population that's working. This is a classic example of what in the 1960s was called lemon socialism. That is, the government pays for the expensive part of the healthcare system, the seniors, the elderly, and the poor, and the private sector gets the profitable part, which is the healthy population, the working population. So if you look at the other side of this, this is government all the way around through here. Government pays for 60% of healthcare in this country already. Part of it is this tax subsidy. That is, the employers pay for private insurance, they deduct it on their corporate taxes, and ends up as a federal subsidy. But the federal government pays for more than a third of all health care already in this country. The state pays for its share of Medicaid, state and local government, as David pointed out, pays for another portion. And then there's other funds. CHIP is the Children's Health Insurance Program. Congress is still trying to figure out whether it's going to renew it. The Veterans Administration and so on. 1 out of every $8 is paid out of our pockets. It isn't covered by any insurance. So that's the picture. It's a different picture than the number of people for the reasons I just explained. This is a picture, this Mondrian diagram here. This is from Uwe Reinhardt, who's the economics professor at Princeton. I don't know if you've ever seen this, but I thought give you a smile maybe. This is the American healthcare system in one diagram. It just shows how complicated it is. This is income along this scale. This is a graph. This is income and this is age. And so if you're, and the age is young up here, you can see young up here and older down here. So if you're old and poor, you're on Medicare and Medicaid. If you're middle class and over 65, you're on Medicare. If you're young and poor, you're on Medicaid or CHIP. And depending on, again, on what your income is, and if you're in the middle here and don't have any other source of insurance, you're on Obamacare. So everybody, and people move around, of course, you know, as you get older, you go from here down to here, and you move from one program into another, and the benefits change, and people can't wait until they get on Medicare, because then at least they know they'll have insurance. Even though Medicare is not a very good insurance program. It was designed 52 years ago, and it has high copays and deductibles. I'll talk more about that as we can move along. So, we're now in the era of Obamacare. It was passed by Congress in 2010, went into effect 3 years later. What does it do? And this is in one slide what it does. It basically requires that people buy insurance if they don't get it from one of these other sources. Okay, there's some limits, of course, to who's eligible. If you're an undocumented immigrant, you're not eligible to buy it with any government support. And if you fall between the cracks of all those programs, you also can't afford it. So you have an individual mandate to purchase private insurance. That's the mandate. There is no public option, even though Obama ran on a platform of providing a public option. When he got into office, he concluded that he couldn't get it passed because the insurance companies would oppose it, because they didn't want competition. So one aspect of it is you're required to buy insurance. The second aspect is there are subsidies to make it affordable, because as David said, and as I will show you, insurance is not affordable to a very large segment of the population. In fact, the median income in this country, household income, is $50,000. At $50,000, you can't afford to buy family insurance. And I'll show you that. So the second is the so-called three-legged stool. One leg is you're required to buy insurance. There are subsidies to enable you to afford it. And the third I didn't put in here, but it is, the third leg is they're required to sell it to you. They can't turn you down because of pre-existing conditions. And then Medicaid is expanded, and David pointed that out, and I will again do the same, that Medicaid is expanded so that anybody whose income is below 138% of the poverty level is automatically eligible for Medicaid. If you accept it, half the states in this, 19 states have not accepted this expansion of Medicaid. It's interesting that they are basically, essentially, except for one or two exceptions, they are the states of the Confederacy. Some connection there, perhaps. The most important aspect, though, of the Affordable Care Act, or Obamacare, is it established the principle right at the beginning of the legislation that every American should have access to health care. Everybody who lives here should have access to health care. It doesn't include, at this point, undocumented immigrants. All right, this is why that legislation was passed. This is the cost. This is another way of showing what David showed before. This is the cost of health care as purchased by employers. Employers get a better deal than individuals, and because they're buying in groups, and there are efficiencies of scale there. So this is from 1999 to the current period, and the cost went from basically $6,000 a policy just before George W. took over to now more than $18,000 a year for a family. The split here is between, this is what the employee today has to pay a substantial share of it. This is national average. I mean, one interesting thing you might see here is that the Affordable Care Act did not make health care affordable. It it is a misnamed law. It had no effect on the rising cost of healthcare, which kept rising, as you can see here. There's no break. The law was passed here in 2010. It went into effect in the end of 2013, and had no effect on the overall average cost of healthcare nationally. So this is one way of looking at the problem we face, is that the cost of healthcare continues to rise. It's now about 18% of our GDP is spent on healthcare. This is another way of looking at it. This is premiums computed in two different, well, this is the family premium, and this is the worker contribution to the family premium. I took this graph from Kaiser Family Foundation, which is one of the more reliable sources, real data from the federal government. So this is the cost of health care, and this is wages, basically. It's general inflation and wages. And the cost, it's basically eating more and more and more out of our dollars are going into health care rather than going into anything else that we use in our daily lives. So one of the consequences of this is that fewer and fewer employers can afford to provide health care, or put another way, a smaller and smaller portion of the population is actually getting its insurance from private insurers, from their employers. And the flip side of that is more and more people on Medicaid, which takes up the slack. This is lemon socialism in action. The government is taking up the slack because the private sector can't afford it. So, what's the nature of this is another consequence of the rising cost of healthcare, is that the insurance that we get is poor and poor insurance. It's Swiss cheese insurance, full of holes. This is a concept called underinsurance. This is from the Commonwealth Fund, which is a New York City-based, very, very good research foundation, I would call it. They do quite excellent research on the healthcare system internationally, as I will show you in a minute. So what's underinsurance? Underinsurance is where you basically have to pay a substantial, like a third of your, it depends on your income, but in this case they say more than 10% of your income if you're not poor, and more than 5% if you are poor. So it's the percentage of the population that had to pay an out-of-pocket cost for its health care, and you can see that it's almost a third, nearly 30% of the population now, and it's getting worse because the costs are going up and the income is not going up in the same proportion. Now, there's one problem with this concept. I mean, there's a serious problem with this concept, which is you might say, well, that means 30% of the population is underinsured. False. We're all underinsured. It's just that we're all not sick. This is saying that the people who 30% of the people were sick enough that they had enough medical expenses that it gobbled up a substantial portion of their income. We're all underinsured because the insurance is getting worse. Here's one way to look at it. This is again from the survey of employers, and this is the average deductible. This is again over just the last 10 years. The deductible has gone from $600 to $1,500. Deductible, you understand, is the amount of money you have to spend out of your pocket before insurance starts to provide you some coverage. So the insurance is poorer than it used to be. It's inadequate. It doesn't cover what it covers, what it should. It keeps people away from getting the care they need because they have to say to themselves, am I sick enough that it's worth my going to the doctor and paying out of my pocket what it's going to cost? Another way to look at it, this is again from the Commonwealth Fund, is surveys which say, did you have trouble paying your medical bills? I think you may have all heard about the statistics on bankruptcy. 60% of all personal individual bankruptcies are a result of medical bills. People get sick, they lose their job, they can't afford their medical care, they go bankrupt. And most of the people, 3/4 of the people who filed for bankruptcy for medical reasons had insurance when they started. But they either lost it because they lost their job, and it was tied to the insurance was tied to their job, or it was lousy insurance. So, the system's out of control. It's not doing what it's supposed to do, which is enable people to get the care they need. So, the Affordable Care Act has not made health care affordable. It leaves millions of people still uninsured, and here's a graph to show it. This is the number uninsured before. This is a projection back in 2010 of what would be if there was no Affordable Care Act. Here's what the Affordable Care Act did. It took the 50 million people that were uninsured in this country and dropped it so it's now 25 million. There's still 25 million people in this country who are uninsured. That's not about 8-9%. So there's millions still uninsured. There's millions more underinsured, as I've just described. Costs are continuing to rise, and those of you that are doctors know that what they're doing is the new what's called the macro law is various kinds of ways to force doctors to become more efficient and to provide more value for the dollar in their care, especially against primary care doctors who have more bookkeeping and less medical care to give. So this is, I think, the major. This whole story is in this graph. I discovered today that I just ran into a book review. I'll tell you about the book in a few minutes. The book is called The American Sickness. There was a review of it. They used this graph as the diagram. I've been using this graph for years as the major story about healthcare. We live on a planet. There are other countries that have healthcare systems. This is the rest of the advanced world. They spend between 6 and 9% of their GDP on healthcare. This is the US, out of control, and they cover everybody. And we don't cover everybody. So they're covering everybody for half the cost. And so what are they doing? They're doing something right, and we're not doing it. Do you have a question or a comment?
Yeah, my sister lives in Great Britain, and she went over there in the 70s, and she exclaimed effusively about their healthcare coverage, in a very positive way.
Yeah.
But fast forward, I haven't really talked to her about it specifically over the years, but one thing I understood from news sources is that they have long waits for service and for surgeries and so on.
They spend 40% of what we spend. I mean, they're down here. I don't know where it's UK.
They're at the bottom.
No, they're at the bottom here. They're spending 7% of their GDP on healthcare. They don't spend enough. I mean, they've had a conservative government for 10 years, and they cut back. Thatcher started it.
So you're saying they spend a lot less than we do, but they cover everybody, but yet they're not spending enough.
They're not spending enough.
So that people don't have long waits, et cetera.
Right. I mean, they don't wait for everything, but,
Yeah.
but they need to spend what the countries up here, they need to spend another % or 2. I mean, that's what people say to me. One thing about these countries, in addition to the fact that they cover everybody and spend half of what we do, is that many of them have no cost sharing. Now, what's cost sharing? That's deductibles and copays. That's out-of-pocket expenses. Britain and Canada, for instance, have no, Canada, a few miles away from here, has no cost sharing. You go to see a doctor and there's no money changing hands. You don't have to think, can I afford to see a doctor? Because it doesn't cost anything to see a doctor. I mean, of course, you're paying for the system through the tax system, but it doesn't cost anything to go see a doctor and see if you're well or not, if you need some care or not. And it doesn't cost anymore. Canada's right here in the middle of these countries someplace. If you look here, here's Canada. So they're about here at about 9%. And I mean, I've published a study of that, and you can't tell, if you look at total costs and compare the countries that have cost sharing with the countries that don't, you can't tell the difference. You don't need to have cost sharing to hold cost down. Why do they have cost sharing? So insurance companies don't have to spend so much. That's why they have cost sharing. They also are healthier. This is, people often talk about life expectancy or infant mortality. Those are public health measures that are quite reliable, but what do they tell you? They tell you about the general status of life in the country, because longevity or life expectancy or infant mortality depends not only on the medical care system, in fact, not mainly on the medical care system, depends on the quality of life, standard of living of the population, the nutrition, the housing, the employment situation. But people have been a little smarter, and they said, let's just look at those deaths due to deaths where medical care can make a difference, referred to as amenable mortality. That is, it's amenable to medical care if you get it. And so here's the United States, 19th in the world on mortality that's amenable to medical care. We spend more and we get less. So what makes the difference? Well, there are two ways to look at it. I want to tell you the two ways. This slide provides one way. I went yesterday to hear a talk by Elizabeth Rosenthal, who's was for a number of years a reporter for the New York Times. And she did a series of articles that some of you may have seen called Pain Until It Hurts, in which she looked at the cost of various treatments and medications. And you know, the colonoscopy that cost $12,000 at NYU Langone, when you can get it for $1,000 at an outpatient clinic and so on. So one way to look at it is that we are the only country. What is responsible for this? Why are we the outlier? That's the question I want to give you an answer to, give you the answer to, in my view. And the answer is, well, thank you. I didn't think I needed it, but you could tell. Okay, what's the reason? We are the only country. Has nothing to do with the fact that we have private insurers, because Germany and France have private insurers. It doesn't have to do with the kind of medical care we provide. We're all using the same technology. It's not all invented here. A lot of it is invented in other countries around the world. The difference is that all of these countries have governments setting the prices. It's through negotiations. It's not, top down. It's negotiations in terms of physician fees. It's negotiations between the medical societies and the government, between the hospital associations and the government. Sometimes the reimbursement is through private insurance, like in France and Germany. Sometimes it's through government single payer, like in Canada and Britain. But the government sets the price. Here, we let every insurance company, every doctor, every hospital set their own prices. That's why you get these wild stories in which the price in a given area, I'm sure in this county, go to one place, it'll be one price, another place will be 3 times as much, or 1/3 as much. We are the only country that treats healthcare as if it's a market. And healthcare is not a market. A patient is not in a position to bargain over price. In fact, you can't even find out what the price is. Partly because, if a doctor orders a test, doctor's not going to know what the test is going to cost because it's being done by somebody else. But also because you don't know what the course of the treatment is going to be. So you can't ahead of time shop around and see what's the price going to be. Anyway, if you shop around, do you really want to get the cheapest doctor? I mean, you want to go to, who wants to go to the cheapest doctor? You want to go to the best, or at least one you're happy with. So that's the difference, is that we are the only, we allow prices to be set by the providers, and what's the limit? The limit is the ability to get paid, and the insurance companies go along with the game, because they just add the prices to their premiums, and the result is what you've seen in what I showed you in the graph here. The prices keep going up, and our income doesn't go up along with it. So, what's the answer? Well, the answer is that we ought to learn from the rest of the world, and the rest of the world says that you need to have government overseeing the medical care system, because it can't be treated like a market where the consumer is the balance against the provider. You can't just go, if you don't like the price of the TV at one store, you can go to another store and get another TV. Medicare doesn't work, medical care doesn't work that way. So government in every one of those countries I was showing on that graph has government overseeing and regulating the system, and in many cases paying for it. But not always. The central thing is that it governs it, it oversees it. So, and we know that it works because it works in this country. We have the Medicare system. The Medicare program, in fact, costs less and has grown in terms of its costs slower than the rest of the healthcare system because it administers its prices. Now that leads to some complaints from doctors because they would like to get the full fees from the commercial side, but it shows that it does work, it's reliable, they get paid on time, it can be done, even in this country. So what's been the consequence politically is that there's a national movement to move to something that works, and what people know, they know Medicare works, why don't we all have it? Why don't we improve it so that it's a more comprehensive insurance system without the copays and deductibles and covers everybody? That's improved, well, you'll see in a second. It's John Conyers, congressman from Detroit, been in the House for 50 years now, came in the 60s. Introduced in 2003, single-payer legislation. Physicians for a National Health Program helped write it for him. It's called the Expanded and Improved Medicare for All. Expanded because it covers everybody. Improved because it covers everything. It doesn't just cover the illnesses of the elderly, but covers, childbirth and a lot of things. And it doesn't have copays and deductibles. It extends Medicare to everybody, provides full comprehensive benefits. You don't have narrow networks because everybody's, over 90% of all doctors in this country are in the Medicare program. It has no cost sharing, no deductibles, and no copays. The studies show that what they do is keep people from getting care they need because people aren't trained to self-medicate. You don't want people to self-medicate. You want them to see a professional and find out where they need care, and you don't want financial barriers to keep them from getting that. A public agency, in this case the federal government, pays the bills, not always directly. If you know a little about the Medicare program, basically it contracts with private companies to process the bills. And is funded through progressive taxes. According to the Conyers bill. And Bernie Sanders introduced legislation a few weeks ago in the Senate to do the same thing. It's very similar, has two differences that I've described here. Again, it extends Medicare to everybody and provides comprehensive benefits and has no cost sharing. That was a bit of an argument, actually. Initially, he did, because he's trying to get, he wanted to not be the only sponsor of this bill. He actually ended up with 17 co-sponsors. He has some cost sharing for medications, basically to encourage people to buy generics, to use generics instead of brand names. So in other words, you'd have to pay a share of the cost if you get a brand name. Again, the public agency pays it. He didn't provide a funding scheme in the bill. I will talk more about that in a second. One interesting thing is, and it will be controversial when we get to debating publicly the details, is he provides a 4-year transition period. My understanding is that he needed to do this in order to get some of the co-sponsors, including Gillibrand. Now why, I'm not exactly clear. To me, if you think about it for a few minutes, this is an absurd concept. This is how Medicare began 52 years ago. This is before computers. This is Harry Truman's Medicare card. It was, basically it was done, people were, how did the government know who to mail Medicare cards to? They were mailed to them. How did they know? Because they were on Social Security, and they had the Social Security files, so they sent everybody who was on Social Security in the mail their Medicare card. This is Harry Truman's. This was before computers. And in 11 months after it was passed, the law went into effect. Yeah.
I'm a little confused.
100%. You mean under the
proposal?
both Sanders and Conyers bills, 100% coverage.
So there'd be
no copays, no cost share.
No more buying another policy.
Right, no more Medigaps. Right, no more supplemental insurance. Right. So we put in a 4-year transition period. The reason that I say it's absurd is that the idea would be in the first year, children up to 18 would be covered and the age would drop to 55, and then the next year to 45, and the next year to 35, and then it would be complete. So what seems to be not noticed is that this assumes that the insurance companies are going to sit still during this period and continue to provide coverage for the rest. Why would they do that? While the guillotine is falling, they're continuing to provide coverage. Makes no sense. Yes.
I see that 18 to 35 seems to be missing in that. There's a gap.
This is the first year, this is second, this is third.
Right, but 35. At some point, you've got to have 18 plus.
The fourth year is everybody. Yeah, the fourth year fills that in. But it doesn't make any sense. I mean, if they could, if we could do this before there were computers in 11 months, we can do it now. People say, well, it's be very complicated to get a single-payer system. Not at all. Starting January 1st, every doctor and every hospital sends all their bills to Medicare. They're already sending their bills to Medicare. They know how to do it. It's not so complicated. And the coverage is complete, so you don't have to say, is it covered? Or, am I covered? Am I not covered? Am I in network? None of that. All that goes, because no other country has the craziness we have. And it's driving us crazy and it makes us say silly things. Okay, here's what we want to do in New York. We want to do this in New York. The Congress clearly is not going to do it in the near term in Washington. So we want to do it in New York. New York, in the 30s started unemployment insurance and started some of the things that became the New Deal. We want to do it in New York. This is Dick Gottfried. He's the Assemblyman Chair of the Health Committee in the Assembly. This is Gustavo Rivera. He's the lead sponsor in the Senate. He's on the Health Committee. The legislation is basically like the two laws I just showed you. It would provide a single state fund that would cover everybody. There would be no insurance premiums. It would the funding. I'll show you the funding in a minute, but basically it would be proportionate to the ability to pay. It'd be like Social Security and Medicare now, in which the taxes are proportional to income, but more proportional. That is, today Social Security is, it's 6.7%. Is that right? Something like that. But it's the same percent for everybody. This would be more progressive, lower for low-income people, higher for high-income people. Again, no deductibles and no copays, no financial barriers to receiving care. That's the central point of the concept that we're advocating for. And the economics show that it costs less than we're now spending. There have been at least 25 studies that have been done in the last 25 years that show that this is affordable. I'll show you the results of one of them in a second. So how's it paid for? It's paid for by you continue to get the Medicare funds, you get the Medicaid, you get the public funds we're already getting. There would be a new graduated payroll tax, 80% paid by employers, because employers are already paying for a substantial portion of health care. But since it's progressively graduated, it means that small businesses that tend to pay lower wages would pay lower taxes, lower premiums. Actually, the legislation doesn't use this word here, tax. It uses the word premium, but it's the same thing. But the point is that one of the problems with our current way of paying for it is, and the reason that small businesses have the problems that David referred to, is that we now pay premiums. So the premium is the same whether, the way the saying usually goes is, the premium is the same for the secretary as for the secretary's boss. The concept here is different. It's very importantly different, which is that the cost of providing insurance for the secretary would be much smaller than the cost of providing insurance for the boss, assuming the boss is making more money. But there would also, and this is important for the financing in New York, is that there would be a tax on non-payroll income, that is on income from investments and from rents and so on. One model that we've developed says that about a third of the funding in New York has a lot of wealthy people who make a lot of money from investments, and they should be contributing to this system. Just because they're not drawing a paycheck doesn't mean they should get away free with the system. In addition, the system would pay for Medicare Part B premiums and Part D premiums. People on Medicare wouldn't have to pay anything anymore for those. Why is that? Because the system is free to if you're a New York resident, if you're a senior, why should you, if it could be free to you? So the system will pay for it. It's included in the financing of the system. And the system would also pay for the local county share of the Medicaid expenses. The bottom line is that if for a person who makes, employee who makes $50,000 in wages, the tax would be 6%, roughly 6%, of which 80% would be paid by the employer and 1 or 2% would be paid by the employee. It's in contrast to today, where if an employer provides insurance for his employees, the average is 11% of wages. The average cost of the insurance to the employer is 11%. Yeah?
Well, today, doesn't the federal government give us money based on how many Medicaid recipients we have?
Yeah.
And how would they know that if we eliminate Medicaid? How would they know how much to give us? And how much would we know?
You would project from the way we are now and what's happened to the economy, from IRS data, from other things. You would not have to establish, there wouldn't be a separate Medicaid program and and Medicaid recipients. We would all be in one pool.
And so we're assuming that the federal government will go along with that and say, okay, you just tell us how much we owe you and we'll give it to you.
Yeah, and if they don't, part of the Affordable Care Act says that states can get waivers to allow this sort of thing. For the federal government can waive the way it gives you your Medicaid money and your Medicare money by giving it to, for instance, in one pool. If they won't, there are ways you can still find out. You can still find out what proportion of the population is Medicaid eligible, and then tell the government, here's what it is, send us our money. The benefits are clear. It provides everything. In fact, it may initially provide long-term care, and if not, the legislation says that within 2 years after passage, it will. You want to ask now, or you want to save it?
Yeah. Since you're talking about payment, I'd rather ask now. So, how does the proposed law address issues with employers in New York and employees that are out of state, and vice versa, New Yorkers who are employed out of state?
Well, yeah, it's complicated because if other states don't have it, but if an employer has employees who live in New Jersey or Connecticut, the employer would continue to cover them the way it covers them now. But New York residents, they would be covered by the tax that they would pay. They'd only pay the tax on the New York residents. They wouldn't pay it on.
How about New Yorkers that work out of state?
That's complicated.
That's why I'm asking.
Yeah. I don't remember how it handles it, but they're New Yorkers, so they're entitled to the care. If they're New York residents, every New York resident is entitled to the care. And so it's up to the government to figure out how to get the money from that guy's employer if he's working in Connecticut.
So wouldn't it be an advantage for a New Yorker to work out of state so they don't pay the tax?
Well,
they'd
have
big states.
I don't know. I actually don't have an answer for you, but they're covered.
No, but the employer doesn't. Yeah.
Actually, it would be an advantage for the employers out of state to pay the New York rate because it's lower.
Yeah.
It's lower.
Yeah, maybe that. Yeah.
Yeah, just have a question. Would that, would the government kind of force us to go to certain medical groups?
No.
Like I just can't
No.
find medical.
No, it'd be like Medicare. You could choose your own doctor because they're all, every doctor would have to take it because I can imagine a few people in Manhattan who might just choose to have only the millionaires for their patients, but generally any doctor would take it, and you could choose who you want to see.
Would it be advantageous for the state to say, well, if everyone goes to this, like I used to care my medical up here, and people, like years ago I had hip, and people, wouldn't the government say, well, everyone has to go there because it would be cheaper in a sense?
No, the payments are the same. Payments are the same to everybody. Payments are the same to everybody.
Wouldn't it be the contrary? I mean, right now people are forced into going to certain providers.
Yeah. Now insurance companies don't limit you to whoever has agreed to take their reimbursement. Here, everybody would take it and be negotiated by the New York Medical Society. So, okay, so here's the economics. Let me just explain. Basically, the purpose of this slide is to explain why this works, why it's in fact financially viable. And what I've done here is I've included long-term care because a colleague of mine and I have developed a proposal for Gottfried and Rivera to incorporate long-term care. So I've put that in here so you can see that works too. Yes?
Is all of this available through
email
or something?
We're going to get copies of it.
An earlier version of this is available on the website of the New York chapter of PNHP. The Friedman study is available on the website of the New York Campaign for New York Health, nyhcampaign.org.
And you will all be getting, if you provided your email address at the sign-in, you will be getting these slides as well as links to the Campaign for New York Health information in an email.
They have my slide set.
Yeah.
So
everybody will have all the slides if you provided your email address.
Yes.
And you said yes to the last column, which said you want you have to opt in.
So let me explain how it works. Why is it true you can cover everybody and still save money? Okay, so first of all, of course, they're going to cost more. Why? First of all, because we still have 8% of the population that's not insured. By the way, what does not insured mean? It means that they don't have insurance for a whole year. It's a result of a survey done by the Census Bureau, which they asked that question. Were you covered at any time during the last year? The answer is no, 8% of the population. Okay, so they have to be covered. What's it cost? Well, it doesn't cost 8% more. Why? Because all the studies say that people who are uninsured still get some care in this country. They aren't left in the street. And in fact, they get about 50 to 60% of the care that the rest of us get. And so when you add it up, it adds up to about just 1.4% increase in total cost of the system. Eliminating cost sharing. Instead of people having to pay out of pocket, the cost is going to be incorporated into the tax or premium that is incorporated in the system. That estimated to add that much. Then, as I say, we have put long-term care in here. Covering it adds another 7%. Medicaid, and the reason, why is it relatively small? It's $20 billion out of a total, this is 2019, and the total expenditure for the state is about $280 billion. It's $20 billion more to cover everybody for long-term care. We're already spending $20 billion through the Medicaid program for long-term care. This covers the rest of the population, the people who aren't eligible for Medicare but who still need some form of long-term care. And then one of the things that was put into the Friedman study that's here is Medicaid doesn't pay doctors enough. The result is only about 1/3 of doctors in this country will take Medicaid. And so one of the things that we've done in figuring out the financing is to assume that doctors and hospitals' fees are all boosted up to basically commercial rates. That adds another cost. So you're adding about 16% to the total cost of the system. But you are radically simplifying the system. You have just one insurer, one place to send the bills. The result is that you save on insurance companies. Here's the situation with insurance companies. Medicare costs, actually this is an exaggeration, it's really only 2%, but the when this study was done, it said it was about 3%, but private insurance costs about 20% of every dollar that goes through them is an overhead. It's in profit, it's in billing expenses, it's in marketing expenses to persuade you to buy their insurance. So you go from 20% down to 3%, that's the saving. Physicians and hospitals don't have to have complicated billing systems. Hospitals have hundreds of people in their billing systems. Here's a graph that shows that. This is for every dollar that goes through private insurance, 28 cents is spent on the billing system. Part of the physician having the staff to handle billing, part the hospital billing department, part the insurer's billing department, and then the insurer's profit and marketing costs. 28 cents. You cut that out of the system, and you save another 7%. Then you can buy drugs. You can both purchase drugs. Already the VA gets drugs from the same drugs for 40% of what the rest of us pay. The Medicaid program in this state buys at discount prices. We can all get discount prices, or the system can get discount prices, because it will have 20 million customers for the drug companies. And then you can, since you have only one billing system, you can see when somebody is doing something funny and badly billing and being an outlier. The result is, remember, you increased about 16%, you actually save almost 25% through these mechanisms. The result is basically 10%. For 10% less than we're now spending, you can cover everybody and have no cost sharing. So, and my last point is, it's popular. This is a survey done just this past April. If you ask people, do you think we should have a federally funded health insurance system that covers every American? Everybody says that if you put them all together, 60% of the population says yes. 80% of Democrats say yes, even 40% of Republicans say yes. And independents, of course, in the middle. So it's popular. The rest of the world shows that it works. It's about time we did it. Okay.
Can I ask a question?
Mm-hmm.
I don't. Theoretically, I work for an insurance company, and my job is to process these papers. What happens to my job when you do this?
There's funding in the bill to help you basically find a more meaningful job. Well, you can maybe work for the healthcare system. It's going to be more patients. Start out and become a nurse, become a technician. Maybe process bills. They're going to have somebody process the reimbursement.
Has been any study in how we absorb? I mean, I don't know how people work in your state.
It's actually relatively small. About 20,000 people.
That's all.
Yeah. That's not quite fair. It's 20,000 in the insurance system.
Yeah.
There's also probably a comparable number of people working for doctors and hospitals. So, and my guess would be a third of those people would still be needed to process it, because it's still a reimbursement system we're talking about. We're not talking about a prepaid system yet.
Let me mention, as we go through the questions, we have Dr. Nisi is here, who, do you want to come up too? Because I think it's important to have a physician perspective on this.
Did you want to talk, or just answer questions? Do you want to give a talk? I mean, you want to?
I'll do 3 minutes.
Fine.
Well, hi, everybody. I didn't know I was talking today, but so I'm Fabio Nisi, I'm a neurologist. I work in here at Poughkeepsie, and I live in Ulster County. I'm a proud founding member of Move Forward New York. It's an activist group out of Gardner, New York. And, well, just a couple of words about single payer. I've worked in private practice. I work in a large hospital system now, and I see the practices that dramatically increase costs and just massively reduce waste. Someone mentioned a large medical practice. These large medical practices put one insurance company against another. They basically pit insurance companies against each other to get the best coverage. It all is done for purely profit purposes. It's a massive waste of money, massive. And like the speaker before, I had to actually run to emergency room, so I heard very little of what actually happened. The patient's fine, and I'm back here. But basically, it's a massive, massive expense. Purely for profit motive. And just thinking of where I used to be in private practice in Kingston, we were a large group of neurologists, and we would have an army of people processing claims, billing, just jumping through useless paper hoops. So I'm very glad to agree with the fact that perhaps we can find more meaningful work for these people, because really it's driving up costs and outcomes are horrific. I don't know if it was mentioned before, but just as far as drag on the economy, it's enormous. I mean, people won't go into, won't open a small business for fear of not having insurance and so forth. And there are a lot of docs that are in favor of this, more than you think. A lot of docs, because we all see the absurdity. Yeah, there are several in the audience, as a matter of fact, that we all see the absurdity of this. So that's my 2 cents. I'm sure.
Any questions?
Good.
In the back?
Yeah, I have a question about rare diseases. Unfortunately, my daughter has a rare disease, and so do I. And mine has led to doctors that won't touch me like that. Not doctors, but dentists. But if I would have to have an operation, I'm sure there'd be doctors that wouldn't want to touch me. And my daughter's disease, the only treatment that is available is $20,000 a shot, and she would be expected to get it for like 6 months or something like that, and they're not sure it works.
Well, that's a perfect example of where single payer actually comes to your benefit, because I can't tell you the number of times we've had patients who have unusual disorders, and you know that you have a colleague, I don't know, University of Rochester, upstate further, right? You have this colleague who's written a paper about this rare disorder, but, up at University of Rochester, they don't take CDPHP or whatever it is and you have to jump through flaming hoops and send letters and everything. People with rare disorders are the ones that would really benefit from a single-payer universal coverage, because it takes finding the insurance approval out of the equation, which is an enormous problem physician offices have. I was wondering what you folks thought about that.
I agree. Absolutely.
There's another question back there.
Hi. I'm very interested in healthcare because my personal story is similar in that I was diagnosed after I don't know how many years with Ehlers-Danlos syndrome, which causes a lot of other health issues. So I sound like a hypochondriac when I start telling people the things that are wrong with me, because it affects the connective tissue. The problem is insurance hasn't paid a cent of any of the treatments that I go for that work for me, because they labeled me chronic and I got written off. So I pay, between my husband and I, and thank goodness I had insurance through my employer and still do in my retirement. The premiums are $16,000 a year, and I don't get anything. I pay $17,000 a year out of pocket for my care, and I have insurance. So something needs to be done about that.
Let me ask you a question. When you were talking about the formal health system that our insurance covers a lot of, there's an informal system, or it's an alternative medicine that actually people spend a lot of money on. And some of it's very good, and I'm not making any judgments about it, but it typically is not covered in this insurance. Would that be covered in this program? Okay. That's Kate.
But there's going to have to be some sort of National Health Service type guidelines.
Yeah. Have to be,
to determine care, just like in the UK, because
right.
it is a finite resource. We have to realize that.
Yes.
My question was along those lines with one of the things that we've seen in the last 50 years is changes in technology that make certain treatments available that are extending lives or saving lives even of newborns that would not have been treatable years ago. Those things obviously cost money, and some of them are very, very expensive procedure requiring lots of ongoing support to maintain life. So how is any kind of a system going to absorb new costs related to new technology? And it just is inconceivable to me that somehow the resources of this nation can support extending everybody's life forever. So I mean, theoretically, you know, if you just kind of think about it from that perspective, how is that issue going to be addressed?
So how do we fund new technology that extends the conditions or life or cures things that we never were able to do it before?
Well, we can build an F-16 for $60 billion. You may change our priorities, maybe.
Well, and the cost won't be the kind of cost that you have here, that you have today, because this is a system where the costs would be administered, the drug costs would be reasonable because the state would use its bargaining power to make sure that it can buy drugs at a reasonable price and not pay, you know, $600 for an EpiPen that costs $20 to produce.
Yeah, I'll sound like a politician, but you reduce waste because you reduce waste. There's massive waste in the system now.
And profiteering.
Well, I'll give you a practical example. Up in Kingston, as a group, we saw these bigger groups taking over. We couldn't hire new docs because they wouldn't get paid as much as these much bigger groups. So as a business decision, we got our own MRI. We're neurologists. We ordered a lot of MRIs. It was a business decision. Did Kingston need a fourth MRI scanner? Absolutely not. That's the practical kind of example that I'll give you. That is a massive waste of money, but with the current system, is favored. And with single payer, you wouldn't see nearly as much of that.
Okay, I'm going to play devil's advocate because I'm all for single payer, but the drug companies will say, well, what's the incentive to us to develop new drugs? The people who build things like MRIs will say, what's the incentive to us to build new machines?
They'll make a profit by selling to 20 million New Yorkers. You know, they're making profits.
They may not make the kind of profit that they're making now.
Right. They'll make reasonable profits. Right. I mean, they sell around the world. They don't not sell drugs to the English or the French or same companies, but half the price. They'll make money.
I can say, absolutely, there are drug companies that sell for much less, the same drug companies that sell to us at a certain price.
And they make their big profits by selling to
They
us.
sell to India, they sell to France, they sell to Germany, and they sell them for a lower cost. I can buy the same drugs that are prescribed here in India, the same brand name, and pay a fraction of the cost and bring it back. And you can do that in Canada.
We are funding global pharma research and development through our drug prices here, not just for American companies, but globally. So, I mean, I'm all for funding research. So let's fund,
there is reasonable profit, right?
You know, so let's do it the right way, not the wrong way by creating a false market, an artificial market, where basically the price you ask is the price you get.
And they also market the example.